in the webinar of World No Tobacco Day, continuing the expression of consolidation and revitalization of tradition to celebrate this day yearly. The member states of the WHO created World No Tobacco Day in 1987 to draw global attention to the tobacco epidemic and the preventable deaths and diseases it causes. Smoking is the leading cause of preventable deaths. Tobacco leads to disease and disability and harms nearly every organ of the body. Even being victim of secondhand smoke is equivalent hazardous. This yearly celebration of World No Tobacco Day informs the public on the dangers of choosing tobacco, the business practices of tobacco companies, and what people around the world and in Pakistan can do to claim their right to health and healthy living and protect our future generations. So I would like to invite Professor Dr. Fatma Mukhtar, Head of Public Health Department, University of Health Sciences, to preamble the current situation of tobacco consumption in Pakistan. Over to you, ma'am.
Assalamu alaikum. Thank you so much, Aisha. The topic of my presentation today is tobacco use in Pakistan: where, who, how, and how many. I'm going to talk about the epidemiology of tobacco use in Pakistan and also highlight Pakistan's achievements in tobacco control. Even today, tobacco use is one of the biggest challenges faced by the world. It is the largest preventable risk factor for the 4 major non-communicable diseases such as cancers, lung disease, cardiovascular disease, and diabetes. The mortality and morbidity associated with tobacco use gives rise to increased healthcare costs and loss of economic productivity. Tobacco is also the single greatest preventable cause of deaths in the world. Globally, 8 million people die every year, according to the World Health Organization, due to tobacco use. That is 1 in 10 deaths worldwide. Globally, there are 1.3 billion tobacco users, and 60% of these tobacco users have expressed their desire to quit tobacco use. We are seeing an increase in tobacco use in the developing world and also in Pakistan, which can be attributed to the low prices of tobacco due to the aggressive efforts of tobacco industry, due to lack of awareness amongst population regarding the ill effects of tobacco on various parts of the human body, and also the steady rise in population. National level data regarding tobacco use, regarding the type of tobacco use, regarding tobacco use with respect to age and gender distribution is derived from the Global Adult Tobacco Survey of Pakistan. This Global Adult Tobacco Survey, or GATS, is a global standard for systematically monitoring adult tobacco use, both smoked tobacco and smokeless tobacco. Smoked tobacco includes tobacco used via cigarettes, e-cigarettes, cigars, smoked pipes such as shisha and hookah, whereas smokeless tobacco includes pan, it includes naswar and gutki, etc. So according to GATS, or the Global Adult Tobacco Survey undertaken in 2014, approximately 24 million Pakistanis were tobacco users, of which 15 million were smokers and 9 million used smokeless tobacco. This slide, also taken from a GATS survey, highlights the tobacco use with respect to age group and gender. And as can be seen, overall 19.1% of the population used tobacco, and of them 31.8% were males and 5.8% were females. And if you look at the rest of the figure, you can see that in all age categories, that is 15 to 24 years, 25 to 44, and so on, in each category, the major chunk of tobacco users were males as compared to females. And the largest proportion of male smokers were in the age category of 45 to 64 years, whereas the largest proportion of female smokers is in the age category of 65 years and above. Secondhand smoke, which is a combination of smoke which is exhaled by smokers and that which is the cigarette that the smoke that is emitted by a lit cigarette, is secondhand smoke, and there is no level of secondhand smoke which is risk-free. Hence, we need to address secondhand smoke also. According to GATS, again, the data shows that about 7 in 10 adults were exposed to secondhand smoke at the workplace. 5 in 10 adults were exposed to secondhand smoke at home. 9 in 10 adults were exposed to it in restaurants, whereas 8 in 10 adults were exposed to secondhand smoke while in public transport. This figure highlights various types of tobacco use, and I want to put emphasis on this last portion, which shows the daily smokeless tobacco users, men and women, and as can be seen, 10.5% men and 3.5% women use smokeless tobacco. The GATS 2014 also shows that about 1 in 4 smokers made a quit attempt in the past 12 months, which is something which we need to pay attention to and help them quit smoking. In addition to the data derived from GATS survey, Pakistan also conducted the Global Youth Tobacco Survey amongst children aged 13 to 15 years, and it was shown that 10.7% children aged 13 to 15 years used tobacco. Amongst them, 13.3% were found to be boys and 6.6% were found to be girls. I also want to highlight this last bullet, which says that almost 2 in 5 ever smokers initiated cigarette smoking before the age of 10 years. These statistics have been taken from the Tobacco Atlas of Pakistan, which shows that 20.6% of adult males use tobacco on a daily basis, and 0.86% male children use tobacco on a daily basis. Percentage of deaths caused by tobacco in 2016 amongst males was 16.99%. The Tobacco Atlas of Pakistan shows that adult females who smoke daily is 2%. Female children who smoke on a daily basis is 0.42%, whereas percentage of deaths caused by tobacco amongst females was found to be 6.92%. Few other facts about tobacco: the annual consumption of cigarettes increased from 292 cigarettes per capita in 1994 to 406 cigarettes per capita in 2007. And according to the State Bank of Pakistan report, 64.48 billion cigarettes were smoked in 2014. Moving on, few highlights on Pakistan's achievements in the line of tobacco control. As is highlighted in this slide, if we compare data from the National Health Survey of Pakistan, which was conducted in 1998, and the GATS survey 2014, we can see that tobacco use both amongst men and women have seen a downward trend. And we need to keep going in that direction. Other milestones achieved by Pakistan in favor of tobacco control is the Prohibition of Smoking and Protection of Non-Smokers Health Ordinance 2002. We ratified the WHO Framework Convention of Tobacco Control, and also the World Health Organization's Empowered Package, which gives out 6 strategies which are monitor tobacco use and prevention policies, protect people from tobacco smoke, offer help to quit tobacco use, warn about the dangers of tobacco, enforce ban on tobacco advertising, promotion, and sponsorship, and lastly, raise taxes on tobacco. And these are scientifically proven strategies which will eventually help get rid of, bring a control on tobacco use amongst the population. Pakistan has also notified pictorial health warnings on both sides of cigarette packages. There's mandatory display of no smoking signs at public places, ban on smoking in public places, ban of smoking in public service vehicles, ban on sale of cigarettes to minors, in addition to ban on tobacco advertisements in print and electronic media, ban on manufacturing, import, and selling of cigarette packs having less than 20 cigarettes, all in line to achieve the tobacco-free initiative of Pakistan. 31st May was the World No Tobacco Day, and Pakistan was awarded by WHO for its effective anti-tobacco steps in Amro region. Lastly, I would want to emphasize that as a way forward, various organizations, the government, the health sector, the academia, educational organizations, youth development organizations have to work hand in hand to achieve a tobacco-free Pakistan. With that, I would end my presentation. Thank you.
Thanks a lot, ma'am, for the comprehensive stats and information. Now, I would like to invite Professor Dr. Javed Akram, Vice Chancellor, University of Health Sciences, who is a world-renowned physician, academician, and researcher. And actually, the name is a brand in itself, and it does not require any introduction. However, it's worth sharing that recently Professor Dr. Javed Akram has been selected by UK's Royal College of Physicians for the Excellence in Patient Care Award. And he is the first Pakistani doctor to be picked for the prestigious award in the category of contribution to the profession. And it really brings honor to home. Professor Saab has led the clinical trials for COVID vaccination in Pakistan, which is eventually a tremendous research contribution. Sir, I would like to request to apprise the audience about smoking bearings in existing COVID-19 pandemic situation. Over to you, sir.
Bismillah ar-Rahman ar-Rahim, and thank you so much, Aisha, for the introduction. I think, as we all know, 31st of May, we always dedicate to tobacco, quitting the tobacco. And this year, the theme is very, very appropriate, commit to quit. So after this very, very good presentation, I think there's not much that needs to be said, but I'll say that as a physician, we all, unfortunately, I'm not a preventive health person, I'm not a public health person, I'm a physician who deals with the curative side. So we see, we have very, very little opportunity to intervene because it is generally too little too late. To us, we only see patients and the families once they have developed either the cancer of the lips, tongue, oropharynx, nasopharynx, and then lung or whatever, which are obviously very, very closely associated with smoking. Or we see patients with end-stage heart disease in the form of cardiac failure or ischemic heart disease, or we see patients of strokes, or we see patients who need amputation because of Buerger's disease or because of the smoking-related issues. We also see patients who have psychological issues because of the smoking. So we all know that one puff of smoke contains more than 4,500 petrochemicals, and most of them are not only carcinogenic, but they have a proliferative effect on the blood vessels, and also they lead to unstabilization of the plaques which develop over time in our vascular bed, whether we are talking of vascular bed of the heart, periphery, or of the brain. So that is why the events, they follow very, very soon. Also, I think not only we do know that as physicians that smoking decreases your lifespan by around 10.5 or 11 minutes. One cigarette decreases your lifespan. So you can calculate that how much your lifespan is decreasing depending upon the amount of smoking and the duration that you have smoked. But also, it also, more importantly to me, it affects also the quality of life. That the quality of life index just deteriorates very, very rapidly by the duration and the quantum of cigarettes that you smoke. So all types of smoke, whether it's shisha, whether it's whatever cigarettes, whether it's cigar, whatever form, is very, very harmful, and not only harmful to the individual who is smoking, but also harmful to people around that person, his wife, his children, or colleagues, or people who are traveling with somebody. So second-hand smoke is a real issue, and second-hand smoke is generally responsible for 50% of the damage of what the smoker gets. So smoking is not only harmful to the individual who is smoking, but also to people around them. I have been working with smoking and anti-smoking campaign for all my life, and in about 4 or 5 countries that I have worked in. In Pakistan, when I came to Pakistan, and my mentor, my teacher, Professor Aziza, who may Allah bless him in heaven, he was the head of the pulmonary, founder of the pulmonology department at KE. He and myself went up to Supreme Court so that the smoking should be restricted to the dedicated area and not on the public places, and we were successful enough. Also, we went against the campaigning or the mafia, which is there, the cartel of the tobacco companies, and we also, to some extent, were successful in countering their advertisement or role modeling with the actors, with the cricketers, with the athletes having a cigarette and giving a message, because our youth is very, very vulnerable. And as you just heard very beautifully from the lecture, that it's the youth which is driving the disease burden, which is driving the tobacco burden. So, and you also heard that quitting is not easy, and the relapse is very, very high. So the best thing would be to reduce the new induction of the smokers at the school level and at the college level and at the university level. It's not enough just to declare our campuses, which we declared 2-3 years ago, smoke-free campuses. It's not, but implementation is the real challenge. And then the second priority is to help people quit. It's very easy for us in the clinics to tell them, don't smoke, it's a poison, this and that. But we have to give them the roadmap as physicians, the pathway, how to make quit smoothly and how to avoid them relapse that smoking again. So right now I am principal investigator, and it's a very interesting thing that this study that we are doing at an international level on harm reduction from smoking is the main sponsor is nobody else but Philip Morrison, the largest tobacco company in the world. The budget of Philip Morrison is about 3 to 4 times the Pakistani budget. So it's a joint we know. And now the Philip Morrison themselves have realized that unless they innovate and unless they really bring in harm reduction from smoking, they are going to be out of business, because this is the first time that they are feeling threatened. And since I am talking to them all the time, so now we are trying to help people to quit. And the best thing is to quit altogether, if one can do it. But if one cannot do it, then we are trying to form a pathway that harm reduction. We know that there are many, more than 4,500 harmful things in one puff of smoke. But we know that two things are most important. One is nicotine, which is an addictive substance and which drives all the addiction. So nicotine, as a physician, to me, it's not that harmful. It's not carcinogenic. It's of course addictive. And the more cigarettes you smoke, and to get the same pleasure, you keep on smoking more and more. Because if you are smoking 10 cigarettes today, your upregulation of nicotine receptors are there in the brain, and then you will need to smoke 20 for the same pleasure. That is obviously harmful, because you will be smoking to get the same amount of pleasure. You will be indulging in more and more quantity of smoking, which is harmful to you and the people around you. But the second part, which is related to burning of the paper of the cigarette, but also burning of the tobacco, is mainly tar, mainly charcoal, mainly petrochemicals, and they are directly carcinogenic. They are proliferative to the blood vessel. They are vasoconstrictive, and they have also they narrow your bronchoalveolar airways, and they are also responsible for the increased mortality in COVID-19. We did a study, we just finished a study where we showed that vitamin D deficiency can play havoc in COVID, because the intracellular signaling in immune cells is dependent on, at least you need to have, if you want to proper signaling, you need 50 nanogram per ml in the intracellular vitamin D3. And if it is reduced, then the immune system will malfunction and you have hyperimmunogenic reaction to this virus. But also the second thing that we looked at that study was the smoker status. The smokers have mortality about 2 to 3-fold more with the age matched, sex matched, and comorbidity matched individuals. So smoking can also bring in harm, and that is also driven through tar and not through nicotine. So now the thinking is that if somebody can quit, nothing like it, that's the best thing that can happen to that individual. But if you can't quit, then at least don't burn the tobacco, don't burn the paper, and heat it and then take it. Of course, it's not harm-free, but then you reduce the harm reduction. Many animal studies, small animal and large animal studies have shown it. The data is right in front of me. It's huge, because we are submitting this study for ethical approvals. So I'm working on these days. It's right on my table. Anybody can have a look at the dossier. Basically, it is heat, not burn tobacco. Now, these devices are available by Philip Morrison themselves. They call them IQOS, I Quit Ordinary Smoke. That's the name of the device, but there are other companies making the devices that if you heat the tobacco, you will get the same pleasure as far as nicotine is concerned, but it will be reducing the harm as far as carcinogenesis is concerned, as far as COPD is concerned, as far as ischemic heart disease is concerned, strokes is concerned, peripheral vascular disease is concerned. So that it can be, used as a tool to bridge, and then it may become easier to quit. But as I keep saying, the best thing is to quit altogether. If you have that degree of willpower, that's the best thing that can happen. But if not, the harm reduction can be implemented. At least we can, as physicians, reduce the harm. So it is commit to quit. That is the theme of this year, and I think I'm very grateful to the Department of Public Health for taking this initiative. Obviously, it is a pro-people initiative, pro-patients initiative, and I hope that Public Health Department, along with us, can come up with a study that what will be the best tool in our community. Of course, there is a lot of international data, but what will be the best tool? One-to-one sort of a talk, a banner, a movie, a media, social media, and where we can have the qualitative and quantitative analysis that how effective. We have to find evidence-based tools which are indigenous to us in Pakistan. They may not be valid in other communities, but unless we do that study, our University of Health Sciences, will be all too happy to support it, fund it, whatever. And I hope we will come up with a very good protocol to find out the evidence-based interventions and cost them. And then doesn't matter how much it costs, the university can afford themselves. If the HEC does not fund it or somebody doesn't fund it, we will fund it. That's the best thing, because then there will be no bias. So I want to see that protocol, inshallah, on my table in about next 2 to 3 weeks. And then we will, funding is my issue, my problem. The idea must come from public health department, because this is a public health issue, and the priority-wise, this is one of the top priority issue, whether we talk of during COVID or after COVID or whatever. So please, all my support in this initiative, and I, inshallah, may everybody live that long. Next year, 31st of May 2022, I want this protocol to be implemented and having the preliminary results. Thank you so much for the opportunity.
Thanks a lot, sir, for the valuable information on behalf of your extensive experience, and your words are really an asset for us always. Now, I would like to invite Dr. Samra Mazhar. Actually, quitting tobacco is not easy, but it can be done. Let's have some valuable knowledge from Dr. Samra Mazhar, a public health professional with over 15 years of experience. She is presently working as Deputy Director of Programs at Ministry of National Health Services. She is also the national focal person for WHO's Framework Convention on Tobacco Control Illicit Trade. She will be exchanging her views about the topic, Commit to Quit, World No Tobacco Day 2021. Over to you, ma'am.
Thank you, Aisha. I thank Professor Javed Akram and University of Health Sciences for arranging this event. The topic of my presentation is Commit to Quit, as we are talking that the World No Tobacco Day theme is Commit to Quit. So why World No Tobacco Day is observed? Every year on 31st May, WHO and partners mark the World No Tobacco Day. The aim of World No Tobacco Day is to highlight the health and additional risks associated with tobacco use and advocating for effective policy to reduce tobacco consumption. This is the only day when smokers are encouraged to start their journey or not smoke at least 24 hours first. Here are some statistics about tobacco use in Pakistan. Pakistan is home to over 24 million tobacco users, including 10 million smokeless tobacco consumers who use a variety of tobacco products. The death toll caused by factors attributable to tobacco is approximately 163,000. This is data from the Global Burden of Disease 2019. The economic cost of smoking in Pakistan is estimated as rupees 143.208 billion. As the theme is Commit to Quit, we have taken some initiative, and I think Professor Javed Akram was also in the PIMS hospital, he knows. The Ministry of National Health Services has established tobacco cessation clinics at 2 hospitals of Islamabad, Pakistan Institute of Medical Sciences and National Institute of Rehabilitative Medicine. But this year, we are also promoting the private hospitals and organizations to establish clinics at their premises. And we have joined hands with the private organizations too. Here are some activities done by these smoking cessation clinics. They have offered their office space and dedicated medical staff. The patient record keeping is maintained. IC material for patient and general public has been developed. A helpline is also working. And tobacco cessation clinic at the National Institute of Rehabilitative Medicine has achieved some milestone. Here is the data of the helpline for which the people contacted them, but still there is a lot more to do. So these were some data of the calls received from various provinces and areas of Pakistan during the last 2 years. So why there is a need for smoking cessation clinics? It is an easy and effective way to treat the tobacco use and dependence. It gives intensive treatment to smokers motivated to quit. It ensures a higher success rate, but also treats difficult patients. Steps by Government of Pakistan. The previous speakers have highlighted some steps taken by the Government of Pakistan. So the public health measure as first is the pictorial health warning. So Pakistan has notified pictorial health warning. This is 60% from 1st June 2019. And in the EMRO region, we are on the 5th number, and globally our ranking is on 50th number for this 60% pictorial health warning. Plain packaging, this is another initiative which we will be working on this year. In the region, only Saudi Arabia has gone for this plain packaging on cigarette packs. The case of 85% pictorial health warning is in the court, and due to the tobacco industry influence, it has not been materialized since then. There's a ban on manufacturing, importing, and selling of cigarette packs having less than 20 cigarettes, and loose cigarettes or sale is also banned, and there is a ban on import of shisha and related substances. Awareness, capacity building of the health professional and awareness for the general population is very important. There were launching of national mass media campaigns in collaboration with various organizations in the previous years. There was a large campaign named Sponge and Tobacco is Hollowing You Out. That coordination with the PEMRA to air tobacco control messages, the public service messages in the past. And during COVID-19 also, we send messages through PTA. Campaigns in cinema theaters across the Pakistan, capacity building sessions as 12,000 enforcers have been trained till now. So here are some of the recommendations of what can be strengthened and what can be done next. Like during this COVID-19 pandemic, it was an opportunity for tobacco use cessation because tobacco can suppress the immune system, and it is a risk for respiratory infections like COVID-19. Corona pandemic is an opportune time to encourage the support for quitting tobacco use by offering cessation. The intervention might include leveraging new technology to reach tobacco users with the information-based and resources, for example, apps, mobiles, quit lines, social media, etc. Providing brief advice to quit in healthcare settings. Providing telehealth services or apps that allow the user to opt in for cessation advice. Increasing access to free or low-cost pharmacotherapic cessation medications and nicotine replacement therapy. Offering behavioral counseling. Revise and update the existing laws, policies, guidelines regarding tobacco cessation. Establishment of smoking cessation units at tertiary level hospitals across Pakistan. Capacity building of health professionals or WHO cessation guidelines. We have started this from the 31st May, and for a whole year, we'll be working on this. Here are one of the greatest achievements, which already mentioned by Professor Fatma. that Pakistan received the WHO World No Tobacco Day Award 2020, and especially the award goes to Ministry of National Health Services Regulation and Coordination. But we all agree that there is a lot more to do, more than this, and accelerating the progress towards a tobacco-free Pakistan is required. I thank you very much.
Thanks a lot, ma'am. Worth sharing information. Thanks a lot, ma'am. Worth sharing information from applied side. Now moving towards another important like butadiene and benzene causes infertility and also difficulty in conceiving. So now we are focusing towards the women health. To elaborate the tobacco health risks on women, I would like to request Dr. Ghazna Khalid, a very humble personality with heights of professionalism and achievements. In a nutshell, she is a gynecologist, public health specialist, and communication strategist. Currently, she is serving as advisor, public health emergencies, NDMA and COVID-19 task force, and also in PM Knowledge Economy task force. Her topic of discussion is tobacco health risk for women. Over to you, ma'am.
Thank you very much, Dr. Aisha, and thank you, Dr. Fatma, Professor Javed Akram, for giving me this opportunity to just talk about different risks that we can have with COVID-19, and also smoking in terms of the general overall risks with in issues to go together with tobacco-related diseases, the epidemiological issues related with tobacco-related diseases, but also specific, Aisha, as you have just elucidated, from a perspective, from the lens of women's health. So I'd like to just talk you through, I'm just having problems with my camera right now, so I'm just going to keep talking, and then when I can, I'll put my camera back on. So what we would like to talk about is, my learned colleagues in the previous discussions have talked about different aspects of tobacco-related disease burden as a whole. Professor Javed Akram talked about secondhand smoke, was especially relevant to children. So if we're talking about women, we need to talk about secondhand smoke and the effects on their children. So if they smoke, their children smoke. And data from different studies in different countries ad nauseum have showed the mortality for women who smoke is approximately double to those who do not smoke. In a nutshell, that describes, in layman's terminology, what the implications of cigarette smoking are. I'd like to focus on the aspects relevant to women, and the risk of premature death is nearly doubled by a single factor, which is cigarette smoking. And that really brings home what this etiological factor, environmental factor can do, and what we can do for smoking cessation. My learned colleague, Dr. Mazhar, just highlighted the need for smoking cessation clinics, which are happening. And that's really, really important as a public health measure, to explain to the general population in very simple language and in non-scary language, what can it do? So I'm going to break down my talk into 3 areas of concern which are relevant to women. So reproductive health effects. We know that women who smoke have aspects that basically are impinging on the reproductive health factors. So smokers are more likely to have low birth weight babies, approximately 2 to 250 grams, less than on age-matched, sex-matched controls for women that don't smoke. They are small for gestational age babies, the increased risk of stillbirths, and the increased risks of neonatal deaths and unexplained sudden infant death syndrome are all increased in smokers. So what if we were to drive a campaign and a public health campaign, we could explain to the population, or the general public health message could be, you smoke, your baby has X amount of risk of dying. And I think that's a very powerful message that will bring home to the population that it's not some airy-fairy, statistic that is we are pulling out of the sky. It is a very real statistic that causes you to have small babies. It causes you to have increased risks of your babies dying. And even when your baby is born, your baby is increased risk of sudden infant death syndrome. This all needs to be relayed in simple terminology. Women who smoke are more likely to experience primary and secondary infertility. We know that through multiple studies. We know that they have delays in conceiving, and this could be due to multiple factors, scientifically, both to do with motility and cilia, but also to do with the hormonal profile of women who smoke or are exposed to tar-containing substances. And as Professor Akram alluded to in his talk, it's the tar-containing substances that damage the cilia, and cilia, as you know, have a key factor in fertility, vis-a-vis things like immotile cilia syndrome. So the immotile cilia syndrome is a pathological component, but smoking can affect the little projections in the cilia that are normally lining the reproductive tract, and they will be damaged, and so hence the reduction in fertility. Pregnant smokers have an increased risk of premature rupture of the membranes, have an increased risk of abruption, which is rupture of separation of the placenta. They have also an increased risk of placenta previa. So when you compare smokers with non-smokers, we have an increased risk that the placenta implants in an incorrect place, so it can cover partially or fully the cervix, which can have implications for bleeding, which can cause PPH, but also has implications for delivery and the reduction in normal delivery. And of course, smokers are more at risk of premature delivery, which therein has its own problems, because premature delivery necessitates neonatal support and the risk of mortality and morbidity in the neonate. We have talked about the general health effects of chronic heart disease, ischemic heart disease, subarachnoid hemorrhage, and stroke with smokers. We are already at risk factors from these diseases by virtue of the population, i.e. the South Asian descent population that we belong to. There's lots of genomic-wide association studies associated with this. So if our women are going to get more inclined to smoking, they think it's a fashionable thing, they don't understand the health implications, they are already at risk of diabetes and heart disease, but if you put smoking on top of that, we compound our risk factors immensely. We also know that smoking increases the risk of cancer. Now we know that lung cancer is the cancer that kills more women than breast cancer. We know that in a general consensus of not just our population, but populations worldwide. The age standardized ratio of lung cancer for women is the highest cancer that there is. But we also know that when you have cervical interepithelial neoplasia, CIN, which is precancerous changes in the neck of the womb and the cervix, then if you are a smoker, you are less likely to clear this. And this would be a really interesting study in our population, because we know that the HPV incidence is high. It's unknown in our population, both of head and neck cancer and cervical cancer. And we don't clear it, smokers don't clear it as effectively as non-smokers. So that's why the risk of cervical cancer, which is an entirely preventable disease and is a sexually transmitted infection in 70% of cases caused by human papillomavirus, is more prominent in smokers because they can't clear the infection. We also know that smokers are at increased risk of breast cancer, but the statistics are not so clear as for cervical cancer. We also know that premenopausal women who smoke are 6 times more likely to achieve higher, earlier menopause, on average 1 to 2 years earlier than non-smoking women. So you age, you have an increased risk of osteoporosis, your babies die at an increased risk. Even if they are born and they're healthy, they have an increased risk of dying from sudden infant death syndrome. And also you have an increased risk of developing the overall generalized cancers, i.e. lung cancer, asbestos-related diseases, chronic obstetric pulmonary disease, ischemic heart disease, and ischemic events affecting the central nervous system. But you also have specific infertility risks and also risks associated with your baby. And not only because anything that affects women and the children are in proximity to the women, your children are more at risk of secondhand smoking diseases, i.e. asthma and pulmonary diseases, and then the long-term effects of smoking in children. So in a nutshell, I would like to summarize that our public health messages, even if it's from university-led fora like this, need to focus on you smoke, you kill your unborn baby. And there was a time that in the UK, where I trained, we had lots of cigarette public health messages, pictorial messages on cigarette packs that smoking kills unborn babies, smoking stops you having babies, and smoking increases your risk of cancer. This should be brought up by academics like us as much as we can, because these are very real risks and this will affect our future generations. And as Professor Akram alluded to, it's not just traditional cigarettes, it's also the tobacco use from traditional methods like biri, like shisha, like hookah. These are all tobacco risks that we need to say, look, we know that you've done this for generations, but we've also improving the health of our mothers and newborns, and this is what needs to be addressed. I thank you very much for giving this opportunity to give me this, for giving the for giving this talk, and I thank Dr. Fatma for her unrelenting support and sort of drive to push this forward in a public health message. Thank you very much.
Many thanks, ma'am. Well, it's the era of information. We all know that smoking causes injurious effects to our health, which may even cause fatality, as very well explained by ma'am. Now, tobacco is composed of combustible compounds, and inhaling the complex chemical mixtures of these combustible compounds through tobacco smoke causes adverse health outcomes through mechanisms that include DNA damage, inflammation, impaired immune responses, oxidative stress, even leading to cancer. To enlighten us about the adverse impacts of tobacco consumption on our health, I would like to request a well-known pulmonologist, Dr. Abdul Wahab Bujaira, who is serving in primary and secondary healthcare department as in charge NCD Clinic, Government Hospital, Shadra. We would like him to acquaint us about the treatment outcome of COVID-19 patients who had history of smoking. Over to you, sir.
Assalamu alaikum. Thank you, sir. Thank you so much for giving me the chance to present on impact of tobacco consumption on health. I would like to start with the presentation. Okay. I hope everyone can listen me.
Yes, sir. Carry on.
Yes, please. I'm Dr. Abdul Wahab, working as in charge of the NCD clinic in Government Hospital Chadra, and I'm representing NCD program on behalf of Primary and Secondary Healthcare Department, Government of the Punjab. I would like to give a brief introduction of the non-communicable disease program. This is an initiative taken by the Punjab government, established in 2017. We have established 36 districts with the clinics, a number of clinics, 130 number of clinics in these districts in all DHQ and THQ hospitals. The main scope of the program is to protect the people of Punjab against the risk of developing non-communicable diseases. I would like to mention here the goal of the non-communicable disease program. This is to reduce the burden of the morbidity and premature mortality related to non-communicable diseases. And main purpose of non-communicable disease program is to promote health by prevention of the non-communicable diseases. And coming to the topic, I would like to mention here that tobacco is the common risk factor for all non-communicable diseases, including diabetes, cardiovascular diseases, respiratory diseases, and cancers. And our program has promoted to quit smoking by using social media, by providing media ads and health promotion through social medias, radio programs, which have been conducted in the previous days, and also awareness through video messages through the consultants. Now come to the topic of impact of tobacco consumption on health. I would like to mention, why do people start smoking? There are parental role models. The children see their parents smoking and they copy it, they start smoking. There is adolescent experimentation, lack of education, and there is also aggressive marketing from the tobacco companies, which can lead the young generation to start smoking. There are also other factors, including stress, anxiety, and depression, which can make the persons to start smoke. And what factors influence smoking? There are biological, social, and psychological factors. And what biological factors can lead to, can make a person to start smoking? Physiological and pharmacological response to nicotine, which is in tobacco. It reaches in brain in 7 seconds and release norepinephrine, dopamine, and beta endorphins. And all these neurotransmitters lead to reduction in anxiety, give a state of alertness and relaxation. And that leads to people start more and more smoking. Social factors that leads to that includes experimentation with the friends, with the peers, and psychological factors. And the main factor is the relief of stress. Now, a bit about tobacco smoking. This is the leading preventable cause of morbidity and mortality. As I already mentioned, this is a common risk factor in all non-communicable diseases, and there is around 100 million deaths in 20th century due to smoking, due to tobacco use. And similarly, the estimated death rate is around 1 billion in the 21st century, overall death rate. The life costs. Tobacco users usually die prematurely because of the diseases they suffer, including COPD, cancers, and as per data, globally 1% dies every 7 seconds from the smoking related disease. And a smoker loses an average of 15 years of life. The situation in Pakistan has already been discussed, so I will skip these things. A message from non-communicable disease program is "Aap cigarette ko nahi, cigarette aapko pee raha hai." These are the brochures that has been kept in the non-communicable disease clinics for distribution to the patients and for awareness purpose. And the main purpose is to make the patients to quit smoking. Now I will come to the different forms of tobacco that has impact on the health. These are mentioned here, including BDs, cigarettes, cigars, e-cigarettes, shisha, which is very common. It has and pipe and smokeless tobacco like chewing and snuffing, etc. And I would like to mention here that 1 hour of shisha use equals to smoke 200 cigarettes, which is around 10 packs of cigarettes consumption in 1 hour, which is very high use of tobacco. Cigarette smoke contains around 4,000 chemicals, and among those, around 60 are carcinogens. These chemicals are carbon monoxide, arsenic, cyanide, benzene, formaldehyde, methanol, ammonia, and there are chemicals which are ciliotoxins, about which in previous presentations it has been discussed that it leads to cilia syndromes, it leads to destruction of the it leads to the immortality of the cilia, and these chemicals include hydrocyanic acid, acrolein, ammonia, formaldehyde, acetaldehyde. Now come to the adverse effects of the smoking that leads to health effects. Major component is nicotine, which is a disturbing thing. Each cigarette contains and endorphins. All these neurotransmitters and hormones, they lead to pleasure feeling, they lead to further craving of using the tobacco. Now, nicotine addiction. What is nicotine addiction? Nicotine has its effect on the body by binding to the nicotine acetylcholine receptors. And these receptors are present in the central nervous system and peripheral nervous system. And once you start using tobacco and nicotine exerts its effects, it provides pleasure and leads to further craving for more use of tobacco, and this circle goes on. People become chain smokers once they get addicted to the nicotine. And dangerous thing is nicotine addiction. Related to this tobacco use is environmental tobacco smoking as well, which is also equally dangerous as active smoking. Environmental tobacco smoke leads to passive smoking among the family members and peers of the active smokers. There is two type of environmental tobacco smoke. One is the mainstream and other is the side stream. Mainstream is which is inhaled and breathed out by the smoker, and side stream is from the cigarette burning between the puffs, from the other end of the cigarette, you can say. And environmental tobacco smoke is so dangerous that if you remain in a smoky office for 2 hours, it is equivalent to using 4 cigarettes. And living together with a pack a day smoker for 24 hours means smoking at least 3 cigarettes. So the family members, the peers, the colleagues, all are at danger if you are an active smoker and you are making other people to smoke passively. And for every 8 smokers that die from tobacco-caused disease, 1 non-smoker will also die due to exposure to the secondhand smoke. And smoke-filled rooms can have up to 6 times the air pollution as a busy highway, which is highly dangerous. Now we come to the disorders and tobacco smoking. What disorders tobacco smoke or tobacco chewing can cause? Almost each and every organ of the body is affected by cigarette smoking, mainly cardiovascular, respiratory, reproductive, as already discussed by the respected Dr. Sabha, and endocrine and GI systems as well, and malignancies of the respiratory and all other systems. This is the picture of a healthy lung and a smoker's lung. If you compare the two pictures, the smoker's lung is full of tar and it is full of deposits. The color has changed, and compare with the normal lung. Lung diseases which tobacco consumption can lead include COPD, asthma, and this is also the focus of our program, non-communicable disease program, to prevent these diseases and to control these diseases. Others include idiopathic pulmonary fibrosis, histiocytosis, respiratory bronchiolitis, Goodpasture syndrome, OSA, and pneumothorax. All these can be caused by the chronic use of tobacco. Cardiovascular diseases include coronary artery disease, atherosclerotic diseases, peripheral vascular diseases, and DVT, pulmonary embolism, arrhythmias. GI diseases, which are very common in our society, peptic ulcer disease, which is mostly related to the tobacco smoking. People who smoke more, they have more peptic ulcer disease symptoms. Similarly, gastroesophageal reflux disease, pancreatitis, and even adenomas can be caused by using tobacco. Reproductive diseases, as already discussed in the previous presentation, they can lead to ovarian failure, pregnancy-related issues, including premature rupture of membranes, spontaneous abortions, low birth weights, and later on, issues in the fetus. Malignancies are the most dangerous thing caused by the tobacco. These include respiratory malignancies, squamous cell adenocarcinomas, large cell and small cell carcinomas. Laryngeal cancers are very common due to chewing of the tobacco, and oral cancers as well. Other body tissues which are involved due to tobacco consumption include esophageal, pancreatic, bladder cancers, and stomach and liver cancers, and even leukemias. They have a risk factor of smoking. I would like to mention here the death toll in the world due to tobacco consumption, which is a major health impact. And this includes around 1,000 million in 21st century. I would like to show some pictures. Squamous cell carcinoma of the piriformis sinus, squamous cell carcinoma of the lip in the pipe smoker, snuff dippers, lesion of the lower lip. So I would give a message to quit smoking before it kills you. And quitters are the winners, which is the slogan of the WHO this year. And benefits of quitting include reduced risk of dying early, reduced risk of developing lung cancer, and reduced risk of coronary heart disease, and reduced risk of dying from COPD and emphysema. And smoking cessation includes behavioral and clinical approaches and pharmacological interventions as well. So at the end, I would like to say that quitting smoking will lead to improve in the quality of life. Thank you so much.
Many thanks, sir, for enlightening us. A thorough explanation by Dr. Wahab. Still, many of us are either unaware or we try to be in the state of not accepting facts, especially when it comes to addiction, that smoking does cause less injurious and cosmetic effects on our mouth too, which includes stained teeth, bad breath, tooth loss, gum disease, loss of taste and smell, reduced blood supply to the mouth, increased buildup of plaques and tartars on our teeth, delayed healing followed by dental extraction. So here we have Dr. Shahnur Azhar, who is a dental surgeon as well as public health specialist, delivering his services as assistant professor public health at UHS, and he's also heading COVID-19 trials. We would like to have his generous opinion on oral health effects by tobacco consumption. Over to you, sir.
जी अस्सलाम वालेकुम थैंक यू वेरी मच डॉक्टर आयशा थैंक यू वेरी मच खास तौर पे यूनिवर्सिटी ऑफ हेल्थ साइंसेज के आईटी डिपार्टमेंट का जिन्होंने इतने शॉर्ट नोटिस पे इतने एक्सेलेंट अरेंजमेंट किए सो फ्रॉम द फिजिशियन पर्सपेक्टिव फ्रॉम द क्लिनिकल पर्सपेक्टिव प्रोफेसर जावेद अकरम ने जिस तरह कहा कि बाय द टाइम फिजिशियन के पास एक स्मोकिंग के इफेक्ट्स के साथ मरीज आता है, उसी तरह डेंटिस्ट भी तकरीबन यही फील करते हैं कि एक तो जनरल हेल्थ के मुकाबले में जो आपकी ओरल हेल्थ और डेंटल हेल्थ है वो काफ़ी कॉम्प्रोमाइज होती है, और पीपल आर विलिंग टू एक्चुअली सेक्रीफाइस इट फर्दर इन दिस कॉन्टेक्स्ट। गालिबन उनका ख्याल ये होता है कि ये उतनी इम्पोर्टेंट नहीं है जिस तरह कोई और कंडीशन होगी। तो जब तक एक्सट्रीम सिचुएशन नहीं हो जाती, तब तक बहुत दर्द नहीं हो जाता, उस वक्त तक डेंटिस्ट के पास कोई जाता भी नहीं है। तो ये कुछ स्लाइड्स मैंने सोचा कि बजाय कि एक चीज़ को नए सिरे से इजाद किया जाए, उससे बेहतर है कि अमेरिकन डेंटल एसोसिएशन का एक डॉक्यूमेंट था जो कि बेस्ड है एक एंटी टोबैको प्रोजेक्ट जो एक उनके अच्छे रिप्यूटेड डेंटल सर्जन ने रन किया था मिशिगन स्टेट यूनिवर्सिटी में। तो मैं खुद भी इस डॉक्यूमेंट से कभी जब मौका मिले तो इसको अपने अपडेट्स के लिए देखता रहता हूँ। मैंने सोचा आपके साथ इसका कुछ पार्ट शेयर कर देता हूँ कि डेंटल प्रोफेशनल्स को ज़रूरत क्यों है ये सारा कुछ स्मोकिंग के हवाले से और कंट्रीब्यूट करने की, क्योंकि क्लिनिकल पर्सपेक्टिव में तो दे आर ऑलवेज रनिंग बिहाइंड, लेट हो चुके होते हैं, और जब तक काउंसिल करते हैं मरीज को उस वक्त तक काफ़ी हद तक डैमेज हो चुका होता है, और काउंसलिंग भी उतनी इफेक्टिव जिस तरह प्रोफेसर जावेद अकरम और तमाम मुअज़्ज़िज़ हमारे प्रेजेंटर्स ने कहा कई दफ़ा इतनी इफेक्टिव नहीं होती। सो डेंटिस्ट को एक रोल एज ए हेल्थ एजुकेटर और मोटिवेटर का लेना पड़ता है ताकि वो पेशेंट को अच्छे टूल्स और क्लिनिकल पिक्चर्स दिखा के एजुकेट कर सके, शायद उसको उसकी अपनी ओरल हेल्थ को देख के, उसकी पिक्चर्स देख के कोई आई वुड से डिटेरेंस आए कि इट इज़ नॉट समथिंग दैट दे शुड कंटिन्यू। और फिर पीडियाट्रिक केयर में जब आपके पास यंग पेशेंट्स आते हैं, उनको एजुकेट करने का एक अच्छा मौका होता है डेंटल क्लिनिक के ऊपर कि आप अर्ली एज से डिटेरेंस या एक प्रिवेंशन की तरफ जा सकें, ताकि इन द एडल्टहुड those adolescents and young adults who come, or the youth that are turning up to dental clinic, they don't take up smoking as a habit, which is where the problem lies, as being already mentioned. So क्यों करनी चाहिए डेंटल टीम को ये सारी एक्टिविटी, क्योंकि पेरियोडोंटल डिजीज मेनली इफेक्ट होती है, मेनली हाईली प्रेवलेंट है इन दोज हु आर स्मोकर्स। इसमें आपके मसूड़ों पे जो स्मोक खुद फिजिकल इफेक्ट मसूड़ों के ऊपर बहुत डैमेजिंग होते हैं। अगर आपकी कोई सर्जरी हुई है, ओरल सर्जरी हुई है, कोई टूथ एक्सट्रैक्शन हुई है, कोई ओरल प्रोसीजर चल रहा है, तो उसमें भी आपका डिलेड हीलिंग बहुत फ्रीक्वेंट कंप्लेंट है। इम्प्लांट्स आजकल तमाम लोग इम्प्लांट्स की तरफ जा रहे हैं और काफ़ी एक्सपेंसिव ट्रीटमेंट है, तो जाहिर है आप चाहेंगे कि वो कॉस्टली एफर्ट और वो सारा ट्रीटमेंट वेस्ट ना हो अगर आप स्मोकिंग कर रहे हैं और उसकी वजह से आपका ट्रीटमेंट फेलियर हो रहा है। इसी तरह कॉमनली दांतों के ऊपर डिस्कलरेशन आ जाती है, बुरा लगता है देखने में भी। जो तमाम फिलिंग मटेरियल्स होते हैं जो कि टूथ रेस्टोरेशंस होते हैं, जो आप आमतौर पे कैविटीज़ को जिनसे फिल कराते हैं, वो ख़राब हो जाते हैं, और आपकी ओवरऑल वेल बीइंग और बैड ब्रेथ, वो सब कुछ जो है वो इफेक्ट हो रहा होता है और आपकी सोशल इंटरेक्शंस को इफेक्ट कर रहा होता है। बीइंग अ एक्स स्मोकर माई सेल्फ, आई टोटली रिलेट टू दैट, और I think it's something that a dental practice should do as a service. There is a lot of biological as well as social reasons to deter your patients to quit smoking, right? So generally आपके blood flow जो gums को reduce हो जाता है और जो nutritional supply reduce रहती है because of the physical effects of the smoke, आपका oral cavity का temperature elevated रहता है जो कि normal flora के लिए damaging है। आपके vitamin C levels effect हो सकते हैं negatively, जिसकी वजह से ओवरऑल पेरियोडोंटल हेल्थ जो है वो इफेक्ट होती है। और अगर आपके मसूड़े कमज़ोर हैं तो फिर आपके दांतों के सपोर्ट स्ट्रक्चर कमज़ोर है, उसकी वजह से आपका टूथ लॉस जल्दी हो जाता है। इसी तरह आपका सलाइवरी फ्लो जो कि ज़रूरी है आपकी, जिसकी हाइजेनिक रीजंस के लिए ज़रूरी है, वो रिड्यूस हो जाता है। सो ऑल द मोर रीजंस टू कट डाउन स्मोकिंग एंड एजुकेट पीपल हु आर टर्निंग अप एट डेंटल ऑफिस। ये भी देखा गया कि बहुत सारे मेडिकल और डेंटल प्रोफेशनल्स खुद स्मोक करते हैं, तो देयर इज ऑलवेज अ रीजन टू continue to revisit and even maybe run the professional development programs for these professionals so that they can be good role models for their patients themselves. So Moving on further, smokeless tobacco सिर्फ tobacco smoking ही challenge नहीं है, बल्कि snuff, dip, chewing tobaccos ये सारे जो हैं आपके tooth decays और oral cancer in the extreme situation उनके risk में इजाफा करते हैं. तो ये तकरीबन खुलासा है जो कि हम अभी तक कर चुके हैं, जिसके बारे में मेनली बात की कि टोबैको या फिजिकल इफेक्ट्स ऑफ टोबैको स्मोक की वजह से आपके पेरियोडोंटल डिजीज हो रही है जो कि टूथ लॉस को तेज कर रही है, आपका दांत गिरते हैं, आपके न्यूट्रिशन जब आपके दांत गिर जाते हैं तो यू कांट च्यू फूड वेल, विच मीन्स कि आपकी न्यूट्रिशन कॉम्प्रोमाइज हो जाती है. उसकी वजह से आप इवन आपकी बात करना, जो आपके फोनेटिक्स हैं जिनको कहा जाता है, वो खराब हो जाते हैं, आपकी आवाज, आपका लहजा चेंज हो जाता है, आपकी शक्ल सूरत भी काफी हद तक चेंज हो जाती है, जिसका तमाम का कुल मिला के असर आपकी सेल्फ एस्टीम पे पड़ता है. सो it's quite a serious situation if somebody thinks it in that way. So as an oral health care professionals, आपके पास अच्छे इंटरव्यूइंग स्किल्स होने चाहिए. बहुत सारे पेशेंट्स हैं वो अक्सर रिलक्टेंट होते हैं अपना टोबैको स्मोकिंग हिस्ट्री के बारे में देने में, रिलक्टेंट होते हैं, टॉपिक चेंज करने की कोशिश करते हैं वगैरह वगैरह. जाहिर है उनको नसीहत करना शायद इतना इफेक्टिव नहीं होता. ये रिसर्च भी यही कहती है कि सिर्फ नसीहत काफ़ी नहीं होती. देयर आर सर्टेन एजुकेशन स्किल्स, जैसे पहले बात हुई कि उनकी क्लिनिकल कंडीशंस दिखाई जाएं और उनको मोटिवेट किया जाए और एज ग्रुप को टारगेट किया जाए एज अ यंग एडल्ट्स, मे बी एडोलेसेंट्स, ताकि वो जब उनको मौका मिले, जब उनको वो ऑटोनॉमी मिले और उनके सामने चॉइस हो, तो वो खुद स्मोकिंग को नो कह सकें बजाय के ऑप्ट इन करें. सो मोटिवेशन वही बेहतर रहती है जो कि इंटरनल हो. सो कमिटमेंट तो सिर्फ क्विट ही नहीं होनी चाहिए जैसे कि इस साल का थीम है, बल्कि कमिटमेंट टू प्रिवेंट भी होनी चाहिए. सो इट्स अ बिग एडिक्शन. टोबैको एंड द निकोटीन प्रोबेबली रिप्रेजेंट बिग एडिक्शन. ये चैलेंजेस हैं, लिस्ट ऑफ चैलेंजेस जो कि तकरीबन तमाम हेल्थ और डेंटल प्रोफेशनल्स और मेडिकल प्रोफेशनल्स को गालिबन अंदाजा होना चाहिए उनका. और ये सारे वो चैलेंजेस हैं जो कि शायद उनके इफ दे आर स्मोकिंग देमसेल्व्स तो ये उनको भी क्विट कराने में मदद दे सकते हैं. So this is what we have to understand, the sensitivities of the smoker, right? Or the presentation goes on and on, but I think that for the sake of this discussion, I'm glad that I've been given an opportunity. Over to the moderator. Thank you very much, everybody, for listening.
Thanks a lot, sir. We have received a question from our viewers, which I would like to ask from Professor Javed Akram Saab, that what strategic measures should be adopted, in your opinion, at both policy making, research, and academic level to tackle culminating incidents of smoking in youths in Pakistan?
Sorry, can you say that again? I'm so sorry.
Sir, we received a question from our viewers that what strategic measures should be adopted, in your opinion, at both policy making, research, and academic level to tackle culminating incidents of smoking in youth, especially the smokeless tobacco users?
Thank you, I think, for the question. I wish I would know, then I would go for the intervention. Exactly this thing, this is what I tasked my public health department during the time that I was given an opportunity. I think we have to have, these measures must be evidence-based. That is what I insist. And evidence-based means that we have to go in a pilot. We have to see which will be the most important tool to convince people to keep away from this most deadliest of the poison that as a human we know of. Obviously, the smoking, we know that for sure is dependent on your education level and your awareness level as a whole. It is the more the educated you are, the more the aware you are, the less likely you are to smoke. And there have been many studies in different communities. Unfortunately, no data from this part of the world, but I think it will still hold true. That is my perception, which needs to be proven. This research must be parked in the public health department of UHS. That is my ambition. That is my wish. And that is why I think Professor Fatma Mukhtar is the right person to design a study, look at the references from all over the world of similar study, and then come up with tools. And then we can talk to the implementing bodies like provincial health authorities, like federal government, and international donor agencies. And then we'll talk about them how for implementation framework. So I personally, I do not know, but I do know that the highest risk is in the schools and colleges. So we have to target our schools and colleges, and also the high risk behavior are people with personality defects, people who come from marginalized communities. Smoking is very high in transgender populations, and they are as much important as any male or female is. So we have to target those populations also, which are with the very high risk behavior. Addiction, because we know smoking has an addiction potential, and so has alcohol and other drug abuse. So the much higher prevalence there. So we have to find the right tool there. HIV patients, the study that I did, about 70% of them were smokers in Pakistan, of about 430 HIV patients that we studied. So that I think it's a very good thing, but as I said, inshallah, my public health department under the very able leadership of Professor Fatma Mukhtar will give us a presentation in year 2022, 31st of May. We dedicate, that's her target. Not only that, I will take it to my ASRB and funding bodies of the university, but whatever money and resources she needs, I'll commit. I gave her a blanket check because it's such an important thing. Any amount of time she wants from me or the university personnel, they'll be all at her disposal, because this is the true jihad that I think is. So let's see what she can answer these questions. Very good presentation by Shanur, as always, about the dental disease. Also, I think since I'm an addict myself, but fortunately I'm an addict of coffee, and coffee has many medicinal benefits, but it has one disadvantage, that I do need scaling every now and then, because I drink espresso coffee and I don't want to drink water with it. I drink it, so that is one problem that I face, and I'm sure people who smoke, they also need to pay a lot to the dentist. I do need to pay a lot for my habit of consuming so much coffee. So that's also one of the problems I wanted to be highlighted. Thank you so much.
Sir, do you think that if we incorporate the primary sector, our basic health units, our LHBs in this counseling sessions, because the first patient encounter is at primary level, and early screening can help us to in culminating the emerge of this iceberg of smokers and pulmonary diseases. So do you think if we incorporate public sector, if we include the government sector, both of primary and tertiary, that they also take part in this intervention, that how can we move towards by involving those sector from where the actual cases are coming? Because in tertiary care hospitals, we receive the patients which are at the stage of advanced disease. तो सर आप उस बारे में अगर कुछ कहना चाहेंगे, हम अगर प्राइमरी सेक्टर के साथ इसके ऊपर एक कोलैबोरेशन करें और अर्ली स्क्रीनिंग पे हम चलें तो?
Again, Aisha, we can be discussing this, but we do not have an evidence. I am a person who believes on evidence-based intervention. So that's exactly what I'm saying, that we have hypotheses. I have a lot of hypotheses, because I think the smoking is become more common in suburban populations than in rural settings, because of the hookah is a part of the culture, hubble dubble and things like that. And also tobacco is chewed and eaten in KPK, especially in the rural settings and even in the urban settings. So this study that I am contemplating on the national level with Professor Fatma Mukhtar, I'm requesting her again and again that she should consider the rural, urban, and comparison of that. In tertiary care, the advantage is that people, if somebody's father is having an amputation of the leg, then these children are quite motivated to quit because they have seen the worst. And if somebody's father is coughing all day long or suffering from bronchoalveolar cancer, then they are quite motivated, and they are, that's a very right thing to do to motivate that family. But as I said, we need to do some studies. We need to bring in the interventions after evidence-based interventions and plan it and it should be having a measurable outcome, that how much we were able to reduce this smoking prevalence in rural dwellings and in the urban dwellings. But of course, if as a I have been tasked many times in my life by different governments, Vision 2025 to build up the vision and this and that. So what I told the government, last government, this government, I've told many times, if it was up to me, I would, bring a revolution to empower my basic health primary care setup, and I'll take away most of the funding from the tertiary care and give it to primary care to strengthen that. Right now, our problem is the primary care, the functionality is not there. So you are absolutely right that is the first line of defense, and that's where the preventive medicine can be practiced in the true sense. But unfortunately, when you do not have anything there at all, where people are not going to them, people are going to the quacks next door because they are functional in those as well. So it's a complex situation, but I think again, inshallah, next year you will be moderating a session where our protocol will be presented after the approval and be funded, and I will see the study in action, inshallah. And preliminary results, interim results will be shared by the team led by Professor Fatma Mukhtar. I'm sure that in 3 to 4 weeks, our ethical review board will be looking at her protocol and hopefully will be approving. And it will be funded in next 6 weeks, the study, and she'll keep us all posted. That's what we want.
Thank you so much, sir, for your support and for your. We're definitely going to submit a proposal, and during the presentations of our worthy speakers, I've already come up with an idea. So definitely, we're going to submit our proposal, and next year, 31st May, World No Tobacco Day, we will inshallah be presenting the preliminary results of our study. Thank you so much, sir, always for being there, for guiding us and for supporting us. Thank you.
I will.
Thank you, sir. Thank you, ma'am. Now, we received another question, and I would like to ask Dr. Samra Mazhar that she mentioned about the clinical. Okay, sorry, sir.
Just a minute. Thank you so much. Just a minute. I will strongly recommend to Dr. Fatma Mukhtar and you yourself and everybody to send me in members of the study group on quitting, commit to quit study group. Let's make this a study group with the theme of commit to quit. And please let me notify a study group of all the worthy speakers. I see Ghazna there. I see a lot of good people there. So I think under that study group, we'll have biostatistician, we have other people from home and abroad. And we will have Philip Morrison involved, things like that. So let's notify the study group and then discuss this protocol there. Thank you.
Thank you, sir. Inshallah, we will inform you. My next question and the last question is from Dr. Samra Mazhar, if she is on board with us. The question is this, that she mentioned about the development of clinics, smoking clinics in 2 hospitals of Islamabad. And the question is that what will be the role of these support clinics, especially in cessation support of the smokers?
Yes, thank you very much, Aisha. Yes, I mentioned that the smoking cessation clinics have been established and to provide counseling and offer help. To help them quit this habit, because we all know that the smoking is a habit first, then it becomes an addiction. So rightly at this time, we are also thinking of starting from the counseling, and then helplines are there to offer help. And I showed you the data that we received calls, maybe not in too much in number, but now we are establishing a network at private facilities too. So the facilities are also contacting that, and with the help of WHO, this IEC material has been established, developed, and provided to these clinics. And there are specific guidelines of WHO, which we will be starting training the health professionals, the medical officers at the primary health level care, because these 2 hospitals are large hospitals. These PIMS is the tertiary hospitals, and NIRM is also of a secondary level hospital. So they have a well established other medicine services. So these are already established. So now we are thinking to move toward the private organization. One organization, the Diabetes Center, they have inaugurated this smoking cessation clinic at their premises. And firstly, it will start with the counseling, and like NRTs are not at present approved by the Drug Regulatory Authority of Pakistan, but still we are trying that nicotine replacement therapy may be started to this group of smokers, or will be requiring more research. I think University of Health Sciences can also help in this for formulating a policy paper, like what can be done clinically for these type of smokers who wants to quit and who need help. So there are specific guidelines of WHO which will be starting from this year. Mainly the purpose is to engage the primary healthcare physicians more, and the community health workers, so how they can identify and the people who need help and who need counseling as a first step. So thank you very much.
Thank you, ma'am. I would like to thank all the experts for their valuable time and enlightening us with the latest trends and facts against the tobacco hazards. I would also like to thank IT department and public health department. In the end, it is in the hands of an individual and his willpower to opt for a healthy lifestyle, and we as public health specialists and clinicians can play a pivot role by extensive evidence-based researches, and further we can pitch it to the government sector. Thank you so much. Allah Hafiz.